Hello and welcome to this fourth year lecture. The first bit of the lecture will focus on renal failure and the second bit of the lecture will focus on hypertension. Please use this PowerPoint presentation in conjunction with your clinical notes. So before we actually start talking about renal failure, I want you to think of the kidneys almost like the mother of the body. The kidneys are there to keep you comfortable. So if they're not working, things start to go wrong, you start to get less comfortable. So that's why we like to sort of refer to the kidneys as the mother of the body. So when we look at the actual functioning of the kidney, we know that the kidney has more than one job to do. One of the things that it has to do is that it needs to filter the blood. From there, you will either have substances that are then secreted into the urine or substances that are reabsorbed back into the blood. We know that the extracellular fluid needs to be regulated, and this happens through the kidneys. And it's not just the volume that it regulates, but it also needs to regulate the composition of this fluid. And then endocrine function. The kidney has a big endocrine role, specifically with erythropoietin production, so in maintaining an acceptable HB, renin production, so in controlling of your blood pressure, and activation of vitamin D, so growth then becomes quite important. How do we evaluate kidney function? So we can look at how it clears creatinine. So in order to do this, a person would have to collect a 24-hour urine sample. You will need to measure the serum creatinine, the urine volume, and you would need to correct for your body surface area. But there's a much easier way. So we use the Schwartz formula, so it gives you an estimated GFR. You will see the formula in your notes, you will see the formula on your screen. So we take the patient's height in centimeters and we multiply it by a constant and we divide it by the serum creatinine. You'll see that below a year there are different constants that you use, but otherwise between 1 and 16 years you can use 40. And this will give you a number. The normal range is between 80 to 120, but to average it out and just make it easier, we use 100 mils per minute per 1.73 meters squared. And this sort of then functions as a percentage of kidney function. So if your GFR, for example, is 60, a nice way to explain to your parents what that means is to say that the kidney is functioning at 60%. And the nice thing about this is that it is already corrected for body surface area. When we look at the staging of kidney injury, there is a pediatric version of the adult rifle criteria, and this looks then at 3 graded levels of injury and 2 outcome measures. The 3 graded levels are risk, injury, and failure, and the 2 outcome measures are loss and end-stage renal disease. So to actually stage the patient, we look at the eGFR and we see how much it has declined from baseline. So a stage 1 is when your eGFR has dropped more than 25%. To do this, obviously, you need to know what is baseline, and this is sometimes very difficult. If a patient has had a previous renal function, you can calculate the GFR and it's then much easier to see the decline. If they haven't had a GFR or kidney function before, then we're going to assume that the previous baseline was 100% and we will start from there. Unfortunately, if we look at all the different types of staging, this one is currently the most accurate one that we have. So the reason we do this is because children with stage 2 or 3 have a higher risk of permanent damage. You will see you can also use urine output as part of this. However, most people will just look at the eGFR. Please do not memorize the urine output for these slides. When we look at staging chronic kidney disease, we will then look at the eGFR, and based on the value that you get, we will then allocate the patient to a specific stage. As soon as you get stage 4, homeostasis can no longer be maintained, and these are the patients that will require medication. Patients that require dialysis, or where you will at least consider dialysis, are your patients that are with end-stage kidney disease, so those with stage 5. When we look at the etiology of kidney impairment, we look at acute causes and chronic causes. So if we start with the acute causes, we divide it into three groups. The first is pre-renal, and this usually has to do with perfusion to the kidneys. So anything that will decrease the blood supply to the kidneys can lead to renal hypoperfusion. Your intrinsic or renal factors are things like ischemic or toxic damage to the kidneys that cause acute kidney injury, pyelonephritis, glomerulonephritis, HUS. Post-renal are things that happen after the kidney, and it's usually an obstruction, and this obstruction can be urinary or venous. When we look at chronic causes of kidney impairment, then it's your chronic conditions such as glomerulonephritis, obstructive nephropathies, congenital abnormalities. So when we actually deal with patients with kidney failure, because we know the kidney has so many functions, there is a nice framework that you can use, and if you remember this framework, then it gets a lot easier to actually remember the clinical signs and the management for kidney failure. So, what is the first one? So, water imbalance. So what I've done for the purpose of these slides, I've allocated each category of the framework with a picture to try and help you remember. So, water balance we refer to as wet. So the next category is waste product retention. So if you don't get rid of waste, we will talk about dirty, and this will then be things like your urea. Electrolyte imbalances. So the reason we have chosen bitter as the electrolyte imbalances, because if you ever have to taste a slow K tablet, open it up and actually taste it, they are incredibly bitter. So a way I've helped you to remember is dark chocolate. I find it quite bitter, so hopefully it will help you remember bitter. We know that the kidneys are important to maintain acid-base balance, so an easy one to remember that is sour. And then the last category, remember we said that your kidneys have a very, very important role in certain endocrine functions. So we've labeled this one dysharmonious, and it will be your HB, your blood pressure, and your growth or your bones. So let's start with the first category. So if we look at wet, what are your clinical signs? So your patients with acute kidney injury can present with fluid overload, so edema, hypertension, ascites, pleural effusions. But keep in mind though, patients with chronic kidney disease are almost always polyuric during the initial periods of gradually declining kidney function. Your oliguria only starts much later in the disease process. So patients with chronic kidney disease won't necessarily be fluid overloaded. If we look at the dirty category, so dirty we refer to as uremia. So what are the clinical signs? If your urea goes up, you can have neurologic symptoms, so things like seizures, suppressed level of consciousness. Gastrointestinal symptoms, so epigastric pain, nausea, vomiting. They can have bleeding tendencies, and they often are very itchy, so they have pruritus. Our electrolytes, so those that are specific to the kidneys, is the sodium, which can either be high or low. Your potassium goes up, so hyperkalemia. Your calcium drops, so hypocalcemia. And your phosphate goes up. However, a high phosphate is unfortunately not clinically evident. So when we look at sour, that's your acidosis. So clinical signs that can give you clues that the patient might have an acidosis are things like your Kussmaul breathing, and if it persists long enough, they might also complain of epigastric pain from gastric ulceration. And then the last group, as I've mentioned, your dysharmonious group. So what clinical signs will you look for? So for your HB, they could be anemic, so you will see pallor. Your blood pressure, so they will be hypertensive. And for your bones, with chronic kidney disease, they actually have something referred to as chronic kidney disease, mineral bone disorder. So these patients don't grow. They're usually quite stunted, and they grow very poorly. What is your approach to a child with acute kidney injury? Most importantly, have a look, assess your patient so that you can determine are there pre-renal or post-renal factors. This is important because a lot of these factors are reversible, and if you can identify these factors early enough and treat them, you will prevent this patient from progressing to intrinsic kidney injury. So if we look at pre-renal factors, as we've mentioned, these are things that will cause hypoperfusion of the kidneys. So assess the hydration status of the patient, check their blood pressure, assess their circulation, try and get an estimate of their urine output. So patients who are dehydrated, who are shocked, poor urine output, these are patients that will have a pre-renal kidney impairment. You will then also look at their dipstick and blood chemistry to help you identify factors which will support this. If we look at the urine dipstick, if there is only a pre-renal element, there should be no protein or blood on the urine dipstick. If you do see these, it indicates intrinsic kidney damage. When we look at the specific gravity, remember, we've already said if you are dehydrated or your kidneys are hypoperfused, you will be retaining fluid. So you'll concentrate your urine, so your osmolality in your urine will go up and you will have a high specific gravity. In order to retain water, you will also then be reabsorbing sodium. Remember, we've said it's pre-renal, so your kidneys are still functioning, so they are still very effective at reabsorbing your sodium. On your serum, we will look at your urea and creatinine ratio, which we'll discuss further on the next slide. During normal kidney perfusion, the serum urea creatinine ratio is approximately 1 to 20. When you get hyperperfusion of your kidneys, this ratio changes as your urea tends to rise a lot faster than your creatinine. When this ratio gets to 1 to less than 10, that's when it becomes quite dangerous because now you're at risk for getting intrinsic kidney injury, so you need urgent intervention. Let's use an example. If you have a urea of 15, if we keep to the normal ratio, you would expect the creatinine for this to be 300, 20 times more. But let's say now your patient's urea was 15, but your creatinine was only 180, for example. That indicates that there is a pre-renal element to this patient's kidney injury. Keep in mind that this ratio cannot differentiate pre-renal from intrinsic renal kidney injury, as a lot of your patients with intrinsic kidney injury will have a period of hypoperfusion before that. All it's telling you is that there is a pre-renal component to this patient's kidney injury. Things that will help you suggest post-renal impairment: when you assess your patient, if their kidneys are palpable or if their bladder is palpable, it might suggest obstruction. Look at the urine quality. If they have recurrent urinary tract infections, think obstruction. And on your abdominal sonar, look for hydronephrosis, bladder enlargement, and bladder wall thickening. So what special investigations are we going to do for kidney impairment? We've actually mentioned a lot of them before, but being the kidneys, obviously we start at the urine. So urine dipstick, urine MCNS. Other things you can send around the urine, things like your sodium, your urine protein, your urine creatinine. On your blood, you can do blood chemistry, so your electrolytes, urea, creatinine. Don't forget your calcium, phosphate, and albumin. Your blood gas, doesn't matter if it's venous or arterial, so you can look at your acid-base balance. Full blood count is important. Remember, we said endocrine function for the kidneys is erythropoietin production, so we need to see what our HB is doing. If they're fluid overloaded and you're worried about any pleural effusions, do your chest x-ray. If you think that there might be stones, an abdominal x-ray would help. However, not all kidney stones are visible on abdominal x-ray. And if you're thinking obstruction, you need to get an urgent renal ultrasound. If there's no obstruction, then you can get in a more elective date. So when we look at the management of acute kidney injury, we will discuss the management specific to the kidney injury itself. But let's quickly first look at your pre-renal and post-renal things, because if you address these things, you can actually prevent the intrinsic kidney injury. So if you've established that there is a pre-renal element to this patient's kidney injury, you need to optimize the intravascular volume or the cardiac output. So if they are shocked, make sure that you resuscitate them properly with the fluid boluses. If they are dehydrated, rehydrate these patients. If you've got them out of shock and their hydration is complete and you are still worried, then you may give Lasix, so furosemide, to these patients. But please don't give it to a patient who is still dehydrated. And if the patient has a low albumin, especially if it's less than 20, you can consider giving them 20% albumin. But if it's a nephrotic patient who's severely edematous, please make sure that you add your Lasix to that. So you can give your furosemide mixed in with your albumin. If there's a post-renal impairment, try and bypass the obstruction. So see if you can insert the catheter. If a patient has a UTI, treat that. But just keep in mind that if there was an obstruction, usually once you've relieved the obstruction, they can have a post-obstructive diuresis. And these patients then tend to dehydrate very quickly. So monitor your urine output in these patients, and if necessary, replace these losses with half normal saline. So we've already spoken now about the management of your pre-renal and post-renal issues. So now we are going to look at specific management with regards to acute kidney injury. So an easy way to do it is to use the framework that I discussed with you earlier to try and figure out how to manage these patients. So let's go through the framework again. Wet, dirty, bitter, sour, and disharmonious. So let's start with the first category, wet. So when your patient comes in, you are not going to know their urine output. The mom might report that the urine output has dropped, but you don't know what the exact output is. So you will need a starting point. So what we do is we look at the normal requirements for the patient's age, and it's then calculated per kilo, and then you will adjust that based on what the patient's requirements are. So for example, if the patient has fluid overload, you will need to cut back on the fluid, and the amount that you cut back by will be determined by the severity of the fluid overload. So for example, patients with moderate fluid overload, you will give them 1/3 of their calculated volume. If the patient is dehydrated, you will compensate for the degree of dehydration. So you will have to give them normal maintenance plus extra, and that is based on the degree of dehydration. When they come in, monitor the urine output. So if the child is old enough to urinate into a bedpan, urinate into the bedpan so that you can actually measure the output. If they're still wearing nappies, unfortunately you will have to put in a urinary catheter so that you can monitor the urine output. Once you know the urine output for 24 hours, then you will be able to calculate the fluid requirement for the next 24 hours. So how will you calculate that? It will be the visible losses, so the urine output, plus insensible losses or invisible losses. And that is calculated at roughly 20 mL per kilogram per day. Just remember, in early acute kidney injury, if your patient is oliguric, you can consider aminophylline. Right, next category is dirty. So if we think of the uremic symptoms, the management will be the treatment of those. So if the patient has epigastric pains and you think has complicated with a gastritis, you may give a gastric antacid. If they are bleeding, then you will need to consider giving them vitamin K and FFPs. When we look at bitter, the management will depend on which electrolyte we are looking at and whether it is high or low. So if we look at sodium, low sodium is probably dilutional, especially if your patient is overloaded, so we need to restrict the fluids. If it is increased, it's probably hemoconcentrated, so you need to give more fluids. If we look at potassium, depending on the actual value of the potassium, then there is different things that you will do. So for all your patients, make sure that you eliminate potassium from their diet. So if you're giving IV fluid, use potassium free. If it's more than 5.5, consider something like K-exolate and a dose of Lasix. If it's more than 6, then there are a lot more things that you'll have to do to try and decrease the potassium. If it's more than 6, you should also do an ECG to see if there are any ECG changes. Calcium. So normally with your kidney injury, you have a low calcium. So you will have to give them calcium carbonate, so tetralac. It's a bit better absorbed than calcium gluconate, but you will also use what you have available. And remember, in your patients with kidney injury, it's not going to help to give vitamin D, as that still needs to be activated by the liver and the kidney. So if your liver is functioning well, it will be activated. However, with kidney injury, we might not see this working as well. So in these patients, we give them 1-alpha, in which it is already partially activated. If your phosphate is high, we will give a phosphate binder. We're trying to aim for phosphate of less than 1.8. If your patient is acidotic, especially if the bicarb is less than 16, then you can consider giving them Sodibic. But please check the calcium first, because if your serum calcium is also low, you should be avoiding your Sodibic until you've corrected your calcium. If you don't do this, you can cause seizures or tetany. So dysharmonia, so if we start with the HB, so if your HB is low, you can consider packed cells. You need to give these patients iron supplementation, and especially if you're looking at your chronic kidney diseases, stage 4 and 5, these patients often need erythropoietin injections in order to maintain a normal HB. If they're not growing well, make sure that you give them their 1-alpha. When we look at the management of hypertension in patients with acute kidney injury, if they are fluid overloaded, you will start first with restricting fluid. In all of your patients, you want to give them a low salt diet. After that, you can consider your medications, and these drugs are added sequentially until you actually reach your target blood pressure. So if fluid overloaded, start with furosemide, so a diuretic. If not, a calcium channel blocker is a good place to start. Please avoid ACE inhibitors in children with acute kidney injury. We will discuss the management of hypertension in a bit more detail in the second half of the lecture. So those are your main groups, but there are a few other things which you might need to treat. So if a patient has seizures, that can be due to various factors in patients with acute injury. You will treat these patients as you would any other patient with seizures to stop the convulsion with lorazepam, and if necessary, you might need to consider valproic acid. If the patients have infections, make sure that these infections are aggressively treated with antibiotics, and consider IV if necessary. And then you also need to look at nutrition of these patients. Make sure they're on a multivitamin, and they should be getting a low potassium, low sodium, but high calorie diet. In some patients, their kidney disease may progress to the point that they would need dialysis. In other patients, there are other reasons they might need dialysis, even though the kidney function is not that bad. For example, a persistent hypokalemia, or perhaps a pH less than 7.2 despite conservative measures. In these patients, make sure you actually discuss these patients with someone more senior, perhaps a nephrologist, to ensure that this patient does in fact qualify for dialysis. So just briefly, there are different types of dialysis. In pediatrics, peritoneal dialysis is the one we use most commonly. And then you will also get hemodialysis and slow continuous hemodialysis. So these are for your very unstable patients in ICU. Your hemodialysis we use for our bigger patients. You can do it in smaller patients, but these are in your highly specialized centers, and these are usually in your bigger cities. So peritoneal dialysis is something that's relatively simple to do that can also be done at the bedside. We will now move on to the second half of this lecture, which is on hypertension. If we look at the definition of hypertension, that is a systolic or diastolic blood pressure that is consistently above the 95th centile for gender, age, and height on 3 separate occasions, and these occasions should be separated by days or weeks. So as you can see, these values will differ for age. There are charts or tables that you can look precisely for this patient's sex, age, and height. What is the 95th percentile? But to make things easier, we've grouped the blood pressures because they only differ by 2 or 3 millimeters. We've grouped them into a table which makes it a lot easier to remember and to reference. So use this. If you really want to be specific, you can then go and find the charts. But it's quite an easy table to remember so that it's not as difficult to determine which patients are hypertensive. When you're measuring the blood pressure, your technique is vital to get an accurate measurement. So the first thing is you need to make sure that you have the correct size cuff. As you can see in this picture, for pediatrics, there are multiple different size cuffs, ranging from cuffs that will fit your prem babies through into your infants, your toddlers, and to your older children. So if we look at the picture of this little boy, the bladder of the cuff needs to go around 80% of the arm circumference, and then the breadth or width of the cuff needs to cover more than 40% of the distance from the acromion to the olecranon. When you take the blood pressure, the child should be calm and relaxed. However, we're in pediatrics, so we know this is not always possible, but just try. If you have a smaller child, often asking the mum to breastfeed the child will calm the child down quite nicely. The arm should be in a neutral position, and then, as I've already mentioned, make sure you have the correct size cuff. Then there are 2 ways to do it. You get the oscillometric measurement. So these are where you use the machines to take the blood pressure. They are designed to measure about 10 millimeters higher than the manual or auscultatory method. The problem with these machines is that very few of them have actually been calibrated or validated for pediatrics. So you can use them, but if it now does record a high blood pressure, then you should be doing a manual measurement. And with manual measurement, you still have the old-fashioned mercury ones, or otherwise the aneroid versions. So I'm not going to go through this slide. It is in your notes on exactly how to measure the blood pressure, because I do have a video which explains it very, very nicely.
Blood pressure should be assessed each office visit for all children over 3 years of age and under 3 years of age for children with special conditions. This video demonstrates the appropriate technique for measuring blood pressure in children. The first step is to select an appropriate size blood pressure cuff. The bladder of the blood pressure cuff determines the appropriate size. The bladder is the inflatable portion of the blood pressure cuff. The width of the bladder should encompass at least 40% of the child's arm between the acromion and the olecranon. The length of the bladder should encompass between 80% and 100% of the arm circumference. A blood pressure cuff that is too small can result in an overestimation of the blood pressure.
Okay, go ahead and uncross your legs for me.
Next, position the child so she is sitting with her legs uncrossed. Ideally, the child has been resting with her feet flat against the floor and her back supported for 5 minutes. The arm should be bare to the shoulder, with the upper arm at the heart level. If the upper arm is below the level of the heart, the readings will be too high. Similarly, if the arm is above the heart level, the readings will be too low. If the arm is held up by the patient, the isometric exercise will raise the blood pressure. The patient should be instructed to relax as much as possible and to not talk during the measurement procedure. When positioning the blood pressure cuff, the observer should first palpate the brachial artery in the antecubital fossa and place the midline of the bladder of the cuff so that it is 2 to 3 centimeters above the antecubital fossa. Placement of the blood pressure cuff 2 to 3 centimeters above the antecubital fossa will allow room for placement of the stethoscope. The mid portion of the bladder of the cuff should be in line with the brachial artery. Place the cuff on the child's right arm about 2 centimeters above the crease at the elbow. only the right arm blood pressure and not the leg can be used to determine whether a child's blood pressure is normal or abnormal. The cuff should fit snugly, but allow 2 finger widths under the cuff. Auscultation is the ideal method for assessment of blood pressure in children. Phase 1, systolic, and Phase 5, diastolic, carot cough sounds are best heard using the bell of the stethoscope over the palpated brachial artery in the antecubital fossa. Lightly place the stethoscope about 2 centimeters below the edge of the cuff on the inside of the elbow over the brachial artery. Keep the stethoscope head from touching the cuff or the child's clothing. The key to good measurement is the use of a high-quality stethoscope with short tubing, because inexpensive models may lack good tonal transmission properties required for accurate auscultation. Apply appropriate pressure to ensure good sound transmission. Determine the level of maximum inflation by palpating the radial artery, inflating the blood pressure cuff, and carefully noting the point at which you no longer feel the radial pulse. To this number, add 20 millimeters of mercury. Next, deflate the cuff. Wait 15 to 30 seconds before reinflation. Inflate the cuff to the level of maximum inflation. Next, release the air such that pressure falls at a rate of 2 to 3 millimeters of mercury per second. The point at which the tapping sounds first appear for at least 2 consecutive beats corresponds to carot cough's sound phase 1 and provides the systolic blood pressure. The point where repetitive sound finally disappears corresponds to carot cough's sound phase 5. In some children, carot cough's sounds can be heard to 0 millimeters of mercury. Under these circumstances, the blood pressure measurement should be repeated with less pressure on the head of the stethoscope. Only if the very low phase 5 sounds persist should muffling of the heart sounds denoting carot cough's phase 4 sounds be recorded as the diastolic blood pressure. Both the systolic and diastolic blood pressure measurements should be taken at the nearest 2 millimeters of mercury. In order to properly interpret the blood pressure, a child's age and height percentile is needed. Any abnormal blood pressure, that is, blood pressure greater than the 90th percentile for age, gender, and height percentile, should be repeated during the visit. Document the blood pressure in the child's chart, including systolic blood pressure, diastolic blood pressure, location used to take the measurement, for example, the right arm, patient's state at the time the measurement was taken, for example, resting or crying, size of the blood pressure cuff used, and the method of measurement. All children should undergo routine blood pressure assessment beginning at 3 years. Proper knowledge and technique ensures accurate measurement.
In some patients, you will need to do a 4-limb blood pressure. So that means you will need to take blood pressure in the legs as well. So to do this manually, you will not be able to auscultate, you will have to palpate. But in order to make all 4 blood pressures comparable, you will also have to redo the blood pressure in the upper limbs using the palpation method. So for the upper limbs, you will put the blood pressure cuff around the upper part of the arm, and then you will palpate the pulse either in the cubital fossa, use the brachial pulse there, or else the radial pulse at the wrist, and then you will palpate when the pulse returns as you deflate the cuff. A palpated pulse is usually about 5 to 10 millimeters lower than the auscultated blood pressure. To then take the blood pressure in the leg, you will use the same size cuff. You will put it over the thickest part of the cuff, and you will then inflate the cuff, and as you deflate, you will palpate the dorsalis pedis or posterior tibial artery, and when you feel the pulse return, that will be then your systolic blood pressure. For both your upper limb and lower limb, you will thus only be able to assess a systolic blood pressure. What is important to note is that your blood pressure in your legs are normally 10 to 20 millimeters higher than in the arms. If you are not using the manual method and you are using the machines, you will then just put the cuff on the thickest part of the calf and set it to take the blood pressure. You will then get a systolic and diastolic pressure. When we look at the classification of hypertension, the American Academy of Pediatrics has adjusted the classification slightly. If you have a blood pressure that is between the 90th but less than the 95th percentile. We talk about an elevated blood pressure. If your blood pressure is more than the 95th centile, but 12 millimeters mercury more, we talk about stage 2. If it's above the 95th percentile, but it's still less than 12 millimeters above it, then we talk about stage 1. If you have stage 2 hypertension without any symptoms, and these are usually just an incidental finding, we refer to these patients as hypertensive urgency. If you have any stage of hypertension, so basically stage 1 or 2, with signs of end organ damage, these are emergency cases. So now we need to look at the cause of hypertension. So in children under 10, our causes differ significantly from those in adults. In adults, most of the time it's lifestyle, things that will contribute to hypertension or essential hypertension. But in children under the age of 10, your cause of your hypertension is usually secondary until proven otherwise. And the first place you need to go and look are the kidneys. 70% of cases in pediatrics of hypertension have their etiology in the kidneys. And there is a nice list of potential causes. So your renal parenchymal diseases are the ones that will be the most common cause of hypertension. The next place to look at 15% is your vascular causes. Okay, so coarctation of your aorta, renal artery stenosis, your Takayasu aortitis. The group after that, 9% are still essential causes. And after that, so sometimes you get a lot of people who jump to this group first, but you'll see there are only 3% is your endocrine causes. So look at your adrenal glands, look at your thyroid, look at your parathyroid. And then your smaller categories, so neurological causes, 2%, and then things like medication, substance withdrawal, 1%. So how do we approach the diagnosis of hypertension? As I've said, it is secondary until proven otherwise. Check the kidneys first. And then check the blood pressure in the legs. Remember we said the second category was vascular. Your coarctation is very, very tricky. Check your blood pressure in the legs. 50% of your patients will not have clinical signs even though they are hypertensive. These are usually an incidental finding during routine examination. Your other 50% will have clinical signs, and these signs will depend on which organs are involved. So there's a variety of clinical signs. They can have epistaxis, they can have decreased vision, they could be complaining of headaches, they could even be in cardiac failure. If you test the urine, if it's now renal cause or renal involvement, they can have proteinuria and hematuria. So it's very important that you think of hypertension when you see patients with these clinical signs that you cannot explain. In your infants and in your neonates, the signs are very non-specific. Failure to thrive, vomiting, irritability. So in these patients, you would need a higher index of suspicion. So how do you approach these patients clinically? With everything else, start with your history. So you need to ask as much detail as possible regarding the presenting symptoms. Family history, especially of hypertension, becomes important. If it's a small child, you want to know the neonatal history, especially if there was an umbilical artery line that was inserted. And then what medication are they on? It could potentially be a side effect of medication. When you examine your patient, you will look at the systems that cause hypertension as well as systems that are damaged by it. And sometimes these two overlap. So for your kidneys, you will look at signs of kidney injury. Cardiovascular, fallen blood pressure. Make sure you feel or palpate all your pulses. Look for brachiofemoral pulse delays. Listen and hear, can you hear any murmurs? Assess your patient for cardiac failure. With endocrine, you will then examine the endocrine organs. Neurological, full neuro exam, and look for things like level of consciousness, focal signs, tremor, things that will give you a clue to a neurological cause, to also see if there's neurological damage from the hypertension. Examine the eyes, look for things such as AV nipping, hemorrhages, papilledema. And with the nose, look for epistaxis. What special investigations are you going to do? So a basic workup for all of your patients will include a urine dipstick, urine microscopy. So remember we said kidneys are the first place to look. Your biochemical profile, your kidney function, your creatinine, your albumin, calcium, phosphate, full blood count and ESR, and a renal ultrasound with Doppler renovascular studies. You want to make sure there isn't a renal artery stenosis. If the patient is symptomatic, you will do the basic workup, plus you will consider tests from this list. And your choice of tests will depend on your patient's history and clinical examination. And if it's really difficult to control, you might need to do more advanced tests such as CT angiograms or MR angiograms, renal vein sampling, renal biopsies. You don't need to memorize this list, but you do need to know the basic workup for patients with hypertension. What is your approach to the management of hypertension? So we will talk about the specific management, but before you get there, you need to look at a few things. So the first thing is you need to determine the severity of the hypertension. Is it a stage 1 or is it a stage 2? You need to look for an underlying cause. Only 9% is essential. For other patients, you will find an underlying cause. Check for end organ damage. You need to decide, is medication required immediately? So in other words, these are your stage 2 hypertensions or a patient with end organ damage. And then you need to decide, is referral required? So you need to ask yourself the watershed question. What is the watershed question? In the case of hypertension, you want to know, is the hypertension transient or not? Transient causes such as pyelonephritis or acute post-strep glomerulonephritis can be managed by a general practitioner. If it's sustained hypertension, these are the ones that need to be referred to a tertiary center for careful evaluation. The older the child, the greater the likelihood of essential hypertension, especially if there is a positive family history. So now we're going to look at the specific management of secondary hypertension. So these exclude your essential causes. So remember, it's a stepwise additive approach. In these patients, if there is fluid overload or oliguria, then you will consider a diuretic. If there isn't that, don't consider it at all. We like to then start with a calcium channel blocker, something like amlodipine. You will start with the dose. If you've reached a maximum dose and you know the patient's compliant and taking the medication correctly, you can add a beta blocker. If that doesn't work, add a vasodilator. Your ACE inhibitors or angiotensin receptor blockers are generally not your first line medication. You must exclude vascular causes first before you can consider these medications. If you have essential hypertension, you will still work with a stepwise approach, but in these patients, you will also start with your general measures. The patients are obese, you need to lose weight. You need to have a good exercise routine. Exercise will be very important for these patients, and you need to limit your salt intake. If you're going to go the route of medication, you shouldn't do it without your lifestyle adjustment or your general measures. You can consider diuretic in these patients, otherwise a very similar approach to these patients. If you have a hypertensive emergency, these patients need to be admitted and you need to start dropping their blood pressure. However, You cannot drop these blood pressures too fast because you can cause cerebral ischemia if you do so. So ideally, these patients should be monitored in an ICU setting, and you should be dropping their blood pressure by a third of the desired amount over the first 12 hours, by another third over the next 24 hours, and by another third over the last 48 hours. So for these patients, please make sure that you do not drop their blood pressure too fast. So that's all that I have for you. So hopefully you have a better understanding of kidney injury in children and hypertension. Thank you.